Yep, that's fine, Rhiannon.
Let me just see if I can get it in. I do it right. Is that okay? Can everybody see that?
Is everybody able to see that, or are they might need to change their gallery?
No, I can see it.
I know everyone can see it. That's great. Thanks, Rhiannon.
It's okay. If it goes funny at any point, just let me know. Move that over there, then you can see that. So yeah, as Karen said, I'm Rhiannon. I'm one of the dietitians for the community dietetics team. I have a special interest and specialise in nutritional support, particularly in motor neuron disease patients and gastro conditions as well, but we sort of all do a little bit of everything. As Karen also said, you're more than welcome to ask any questions at the end and write them down as we go as well. We also have a survey that I'll ask you to complete if that's okay online at the end, but I can show you the link to that. So the aims for today are to provide participants with the knowledge of how to monitor and support their patients' nutritional status and hydration. The learning outcomes to understand how and when to refer to our dietetic service, to be able to identify patients at risk of malnutrition, to be able to be aware of appropriate ways to support patients with their nutrition and hydration. So we'll go through briefly our service, malnutrition and must screening, food first, hydration and nutrition links and resources. Can I just check, is it just this screen you can see, or can you see other things?
It's just the slideshow that I can see.
That's
I can't
fine.
see any of your background or anything.
That's fine. I just didn't want it to be tiny for you. So yeah, we're the community dietetic service. We work across East and West Kent. That is our telephone number if you want to take that down, but it's also on Rio. To refer to us as well, the form is on Rio if you're able to access that. If not, more than welcome to ask sort of GPs or other healthcare professionals to refer into our team or just ring us. So we work across both adult and paediatric patients, and we work in quite a lot of variety of locations. So it can be really dependent on the patient's needs. We have clinics, they can be telephone, video, and we are doing some face-to-face clinics again, which is nice. Community hospitals. We visit nursing and residential homes, care homes, and also do home visits to housebound patients. And in the East Kent, just the East Kent at the moment, we also do group sessions, particularly around things like diabetes. So, as I mentioned, we all sort of work within lots of areas, although we might have particular interests, but we cover things like malnutrition, diabetes, so that can be type 1, type 2, gestational. We do weight management, including pre and post bariatric surgery, modified texture diets, oncology, gastro as well, so things like IBS, Crohn's, celiac disease, allergies and intolerances, surgery recovery, COPD, cardiac rehab. So yeah, quite a wide variety. And we also work really closely to the acute hospital dietitians and the home enteral nutrition dietitians as well, and we're all part of the same team. So this is just a sort of a quick overview, really. So the best way to prevent malnutrition is to eat a healthy, balanced diet. And as you've probably all seen, this is the Eat Well Guide produced by the government. And it just goes through sort of the main food groups trying to include. We get people to try and include. Doesn't have to be sort of over a day, it can be over a week. And we tend to say sort of just trying to think about the shopping trolley and what's within it. That is available on the government website as well, if you just Google it as well. So if you did want that, the PDF's on there. The thing we wanted to focus on today, so thinking about malnutrition. So malnutrition can be a cause and a consequence of disease, unfortunately, and it is a serious condition that happens when the diet doesn't contain the right amount of nutrients. So we can refer to poor nutrition as in undernutrition, meaning not getting enough nutrients, or overnutrition, in that people are getting more nutrients than needed. Malnutrition is a major public health issue. It costs the NHS over 19 billion per year in England alone, so it's huge. We tend to find that's from things like increased GP visits, longer hospital stays, increased readmissions to hospital, prescribing costs as well. There's approximately 3 million people in the UK who are malnourished or at risk of malnutrition. And as the slide says, 93% are living in their own home. So for sort of our community dietetics team, again, that's huge. So what are the causes of malnutrition, and what are some of the red flags to look out for? So particularly when you're sort of visiting patients or working with patients, some of the things we say to look out for. So impaired intake. So yeah, might be inability to eat, the environment, social situation, particularly with socialization and social isolation at the moment. Is it that it's the mobility limiting the getting foods and preparing foods? Do they have a condition that impacts on swallow, or is it literally just cognition in that they can't see the plate, they don't register that they've already eaten, or haven't eaten? Impaired digestion and or absorption. So this can be medical, or it can be surgical problems affecting the stomach, intestine, liver, or pancreas. So for example, by that I mean things like chronic pancreatitis, inflammatory bowel diseases, so Crohn's, ulcerative colitis, liver disease, or bile acid malabsorption. Altered nutrient requirements. So this might be if somebody's got raised requirements. So for example, we know in COPD that very often patients' nutritional requirements are a lot higher because of the breathing and sort of the extra energy that's needed with every activity. And then excess nutrient losses too. So as it says, things like vomiting, diarrhea, the patients might have drains or stoma losses. Some of the consequences of malnutrition. So I won't go through all of them, but as you can see, there's quite a lot. So particularly things like increased susceptibility to illnesses, infections, pressure ulcers, particularly given everything that's going on at the moment. That's a big concern, not only for risk of sort of pressure ulcers as well, but worsened healing too. So it can just take longer. Increased risk of falls, just feeling really low, lethargic, thinking about quality of life for our patients. So nutritional screening and MUST. So MUST stands for Malnutrition Universal Screening Tool. And this was launched in 2003 by the Malnutrition Action Group, which are part of BAPN. I'm sure lots of you are aware, but MUST goes through sort of thinking about patients' weight loss, calculating height with weight for BMI, and sort of thinking about how acutely well the patient is and if they've not had anything to eat for a certain amount of time. We then add these scores up, and this gives us the MUST score, and that allows us to sort of, I guess in a way, rate the patient's risk of malnutrition. The BAPN website, so when I'm saying that's BAPEN, they have got really good resources on their website. So this is the sort of step-by-step guide. And I put a link to that at the end as well. So you can grab that at the end if you find that helpful. For a few of the patients we see, just taking the weight just isn't sensible. It's sometimes not realistic. So, for example, poor mobility, or if they have fluid overloaded, so edema, or ascites. So we can take a mid-upper arm circumference, so MUAC for short. We do this by, you sort of get from the pointy bit on the top of their shoulder down to their elbow, find the midpoint within that, and then wrap the measuring tape round. I think it goes up to the next slide. And measure that within the centimetres. That then helps us to sort of estimate the BMI. It's good to get a trend of this because the initial measurement acts more like a baseline, and then it gives the following measurements give us something to compare to. There are some exceptions to MUST, so the screening tool. Patients must be adults, so over 18. It's not appropriate if they're on ITU or intensive care. Patients are pregnant or terminal, where it's just not in their best interest to complete it, and obviously getting the patient's consent. So improving intake and care planning. So like with everything, a care plan should be focused on patients' needs and wishes. I think the most important thing is exploring sort of the underlying reason for why they've got the reduced intake, and thinking about steps to help overcome it. So by that, I mean thinking sort of, is there a physical problem? So for example, is it literally just that their dentures don't fit anymore? They can't find their dentures? Is it a swallowing concern? Is it that they don't have the assistance they need during during meal times? Is it cognitive? So for example, like I said earlier, can they actually see the plate in front of them? Do they not remember that they haven't eaten? Is it sort of that they're not getting the hunger signals that they perhaps were before? Is it the environment? So again, socialization, can't get that out today. Social isolation is a huge thing. Sort of eating on your own just isn't as appealing for some people, especially if they might have always been used to having family and partners present, and now they're not. Is the patient sort of laying in bed a lot, meaning are they not getting out of chairs and out into the chair and enjoying meal times? When we're thinking about care planning as well, it's about trying to make a detailed food and fluid chart. So including snacks, including fluids, thinking about what's been offered and what's been accepted or refused. We find that having a in-depth food chart for shorter is much more beneficial than sort of just having a food chart that doesn't include much information and going on for a long time, because it's just more work for the people filling it out as well. And obviously referring to the right healthcare professionals. So for example, is the patient low in mood? Do they need input from the GP? Is it to do with equipment? Do they need input from OT? Is it swallow? Do they need input from a speech and language therapist? And by all means, you can refer to us as well. First line dietary advice. So yeah, as sort of it is in the name, malnutrition is best treated with food. It's about trying to make meal times as relaxed and as beneficial for that patient as possible. So making mealtime social, involving families and relatives in meal choices, thinking about environment, positioning. Are they able to get out in the chair and sit at a table? Can they physically reach food and drink? Are they able to lift the knife and fork themselves? Mouth care is hugely important as well. If people have sore or uncomfortable mouths, do dentures fit? Again, can they reach their dentures? And also thinking about access to food. So again, we noticed this in lockdown, but if people can't physically get the food, then they're not going to be able to eat the food. And it's just about trying different options as well. So just learning what is most effective for that person. So we say trying to aim for little and often if people aren't able to manage their normal meals, and thinking about high calorie, high protein ideally as well. So little snacks, it could be things like yogurts, custard pots, little trifles, cheese and biscuits, sweet biscuits, whatever the patient likes. Food fortification is really handy as well. So by adding, for example, something like mashed potato, adding in an extra dollop of cream or butter or cheese. If they have something like fish and veg, can they melt a little bit of extra butter over the fish or the veg? Soups, can they put a dollop of cream in there or just a little bit of drizzle of oil on top? And then you're finding that they're not making sort of the meals big and huge, but they're getting the calories in every mouthful. Full fat milky drinks as well, if patients like milky drinks, so plain milk, milkshakes, Horlicks, hot chocolate. Milk's really good in terms of the calories and the protein as well. Yeah, protein-based snacks, so again, similar things to what I mentioned, so the cheese and crackers, little mini pork pies or little bits of, chunks of chicken you can get, keeping things easy if appetite's reduced, so there's just sort of less thought behind it. Oral nutritional supplements, we'll talk through that briefly shortly, and again, patient nutrition resources, so I can send you some links at the end for things there that you might find helpful to give to patients or clients. Another thing that's coming is something else patients might find easy is finger foods. So especially if they're having difficulty with cutlery, or if it's a patient that's sort of particularly always on the move, finger foods can just sort of help to maintain that independent eating. So hydration, thinking about sort of the physical signs. So is the patient thirsty? Do they sort of look withdrawn? Are the lips dry? Urine colour. Trying to aim for a nice sort of light urine colour if possible. Some of the things that could possibly affect fluid intake, so dysphagia, so swallow concerns. We know that patients typically tend to drink a bit less when it's thicker, maybe because they're not enjoying it, or maybe just because they don't particularly see it as a fluid. Thinking about sort of the need, is there a barrier there between the patient needing to go to the toilet a lot, stopping themselves drinking because their mobility isn't great and they're not able to get to the toilet? Is it that the carers aren't there to support them, so they're fearful of going to the toilet? Do they have sort of the right continence, what's the word I'm looking for, equipment there? Again, are they physically able to reach the drinks and get everything that they need when people aren't there to help them? Is it possibly just related to age, in that we know that the first mechanisms can decrease as we get older? We recommend about 1.5 to 2.5 litres of fluid a day. Tend to ask patients to aim for at least 8 cups, and anything counts towards our fluid. So it can be tea, it can be coffee, it can be hot chocolate, it can be juice, milk, water, whatever they enjoy. The diuretic effect of caffeine isn't significant enough for us to exclude sort of tea and coffee, so we still say it includes, which is really good. Fluid is really important as well, particularly for wound healing, and especially when we've got this nice weather. I don't think a lot of people realise that actually fluid requirements will increase. So nourishing drinks. So when patients are at risk of malnutrition, nourishing drinks are one of the best things to offer, particularly if they're finding food is a bit more difficult. So nice milky based drinks, homemade milkshakes, again fortifying them, so adding a bit of extra ice cream in there, bit of fruit in there, a bit of honey. Smoothies, even things like juices provide a good amount of calories, so apple juice, orange juice, anything that they like. And over-the-counter supplements too, so you've probably seen things like Complan. well as the over-the-counter supplements, patients can be prescribed oral nutritional supplements through the GP. There's lots of different types of these, which I can show you shortly. These are to be used when we've sort of tried the food first approach, and the patient's just not able to tolerate them, or they don't are not able to tolerate it, or not able to just manage enough. So then we can consider the supplements. And it's really important that we identify the must for this, because we obviously have to give clinical reasoning to use them because they cost money. So I've put some pictures of the common nutritional supplements up here, which you might have seen. In Kent, we have first line supplements, which tend to be the powdered ones, so things like Aim Shake, Complan and Scandi Shake. So we always try and get patients to use these ones first if they enjoy them and if they're able to. So these you typically mix up with water or milk, ideally milk, but we do actually have a new smoothie one as well, which is quite nice, and you mix that one with water and it's just different flavours. The second line supplements, then, if patients aren't able to tolerate them or they're just not appropriate. So, for example, if somebody has reduced mobility, we wouldn't ask them to stand and mix up a milkshake. So then we have sort of the ready-made ones, so things like Forty Juice, milky ones, things like Fortisip Ultra Plan, and we got pudding style ones too, so not Nutricreme and things like Forticreme. So there's things to think about. So lots of flavours out there. So it's finding the flavours that patients enjoy, thinking about compliance as well. There's no point prescribing something if the patient isn't going to use it or doesn't like it. We also have to take into consideration things like dysphagia. So are they on thickened fluids? For example, the Ultra Plan is, just thinking because it's changed recently, when it's chilled, or at room temperature is IDSI level 2. So if patients are on level 2 thickened fluids, if it's warmed, then it changes. But we can support you with working that out for patients. These are, like I mentioned, prescribed and they're regulated as well. So they would need to be on patients' MAR sheets and signed off like other medications. So nutrition in dysphagia, I think going back a step as well, I think if patients are really struggling with oral intake, please ensure they're under our team. And if you feel that for whatever reason, whether it be medical or surgical or just reduced appetite, we can always consider enteral feeding, so tube feeding as well. Obviously we do everything we can to prevent that. But we're the team to sort of support discussion around that if needed. So nutrition in dysphagia, so that's swallow concerns. So the IDSI framework provides terminology about the food textures and food and drink thickness as well. So it goes from 0 to 7. And it would be the speech and language therapy team that make recommendations on what patients should be having. And then we can support patients with sort of fitting the foods into the recommendations. So, for example, some patients might be recommended to have level 6 soft and bite-sized food, but then level 2 mildly thick fluids. Who might need a modified textured diet? So some patients do have difficulty with chewing and swallowing. Some situations that this might occur is things like stroke, motor neuron disease, Parkinson's disease. We see it quite frequently in dementia, issues with the esophagus, and again dental issues. So if patients were to eat and drink, so for example, if they were recommended by speech and language therapists to have level 2 fluids, which is thicker, and then they were to have sort of the normal fluids, they would be at risk of aspiration. So sort of the fluid going down the wrong way and causing chest infections, and patients can become quite ill. There's actually research that suggests that 22% of adults over 55 years have a degree of dysphagia, so it's actually quite a lot. So we do find that patients are likely to have a lower nutritional intake and be at higher risk of malnutrition when they have a texture modified diet. Again, it could be just due to the fact that the food is different to what they're used to. It can be due to sort of other things that are going on, so cognition, again related to the sort of the reason for the swallowing concerns. So it's really important that we not only still get that balance, but really try to fortify foods as well. So just getting the cream, butter, cheese, a little bit of extra oil in where we can. But also making it as appetizing as possible, because you can appreciate if it's sort of just a pile of puree on your plate, it doesn't tend to look that nice. But companies are getting a lot better now with sort of making things into the shape of foods, which is really good. Yeah, so that's all for me for now. Does anybody have any questions?
Thank you, Rhiannon. That was really, really interesting. And something I didn't realise actually was that once sort of speech and language therapy have made their recommendations in dysphagia, that you can actually then dietitians can work with you to sort of really personalise that diet for the client. So that's something even I have learned today, so thank you. I do have a question from Paul Brown, and Paul has asked, do you think the BMI is slightly controversial, especially when someone has a high muscle density?
Yeah, so it definitely can vary for patients. So particularly, like you say, if the muscle to fat ratio is different. Stereotypically, people always say sort of in people like rugby players where the muscle is denser. So yeah, it can be. We use it as a guide. So for example, we might come across patients that have a healthy BMI, but actually, are they eating and drinking? What was their weight before? What else is going on? Because patients can have a healthy BMI and they could be eating absolutely nothing. So yeah, it's just thinking about the whole picture.
Okay, thank you.